Welcome back again, and thank you for joining us. I'm Dr. Xavier Keutgen from the University of Chicago Medicine, and we have our fantastic morning panel that is joining us today for the treatment sequencing panel. So we'll start with Dr. Ahmed from the University of Chicago, who's our IR specialist, Dr. Courtney Lawhn Heath, who is our nuclear medicine from the University of San Francisco, Dr. Andy Liao from the University of Chicago, medical oncology, and then Dr. Jennifer Shan, who is also joining us as a medical oncologist from the Dana-Farber Cancer Institute. So we'll dive straight into the treatment sequencing panel slides. As you probably know, there are some guidelines out there that we use as clinicians to be able to, or at least to try to figure out how we treat certain cases and in what sequence or in what order we treat those patients. But if you look at, this is sort of a simplified version of things, if you look at the red part here, which is for metastatic disease, for neuroendocrine tumors, there are a lot of different options that we can fall back on depending on different cases. And so I hope that these 4 cases we're going to talk to you about today will illustrate how different things can be from one patient to another. So let's jump right into the first case. This is a 49-year-old female who presents with flushing, diarrhea, weight loss, and abdominal cramping after eating, usually about 30 to 60 minutes after eating. She gets an abdominal CT and an MRI. And the CT shows, as you can see here, that there is a roughly 2 centimeter tumor in the distal small bowel that's partially occluding the lumen of the small bowel. And then the MRI with EOVIST shows that there are multiple liver metastases. The radiologist calls them innumerable. The blue arrows just point to some of them, but essentially all the dark spots here in the light gray liver are tumors. So let's start. So the patient gets a biopsy, a liver biopsy, which shows a well-differentiated neuroendocrine tumor. It's a grade 1 tumor. The Ki-67 is less than 3%. And obviously, this is stage 4 because the tumor has spread. So serotonin is quite high at 1,330. Chromograninase 4,119. And as good clinicians, we got a dotatate PET-CT next, which showed that there was mostly disease within the abdomen, with most of the disease here in the liver, quite a bit, actually a lot of disease, and then the primary tumor here with some lymph nodes in the right lower quadrant. So Dr. Chan, what would you do next for this patient when she comes to your clinic?
I think what's interesting to note about her case is the extent of liver disease that she has, as well as her symptoms that are compatible with carcinoid syndrome with the flushing and diarrhea. I think whenever there's pain, especially after eating, you have to worry that there may be partial obstruction related to the primary tumor, or even if there is mesenteric disease, some element of mesenteric ischemia that's causing some pain after eating. So I think in a case like this, there is a clear role for somatostatin analog therapy to help with her symptoms of carcinoid syndrome. But I would also make sure that she is seen in a multidisciplinary setting like this to especially get surgical input regarding resection of the primary tumor with the pain and symptoms she's having.
Great. So that's exactly what we did. We started on somatostatin analogs, and her symptoms improved minimally. She states that her flushing got a little better, her diarrhea minimally improved, but the cramping remains. So she was, like you suggested, discussed at a multidisciplinary tumor board like we are having right now. And the general consensus was exactly as you suggested, that perhaps because the cramping didn't really get better on the long-acting octreotide, and because the CT suggested that there was quite a bit of narrowing of the small bowel lumen where the small bowel tumor was, she could potentially benefit from surgery. Now, Dr. Liao, why did we get a preoperative echocardiogram in this patient? Does this matter before we would take somebody to the operating room?
Yeah, I think for anyone who has carcinoid syndrome like this patient has, we would always worry about carcinoid heart disease, so tricuspid valve abnormalities, and so it's really to help with the surgical planning to make sure that if they have any underlying carcinoid heart disease, that gets addressed first to optimize the surgical risk.
Thank you. So we took her to the operating room, did a laparoscopic right hemicolectomy. We took out her gallbladder to prevent gallstones since she was expected to be with that much liver disease on long-acting octreotide. We also did a liver wedge resection just for the pathology report, and the pathology essentially remained the same as the liver biopsy. So this was a well-differentiated tumor, low grade. So at this point, after the surgery, she says her cramping improved, but the symptoms are still pretty bad. So as a matter of fact, she thought that the flushing and the diarrhea really didn't get much better since we talked to her last. So now I would ask Dr. Lawhn Heath, what are the options here for somebody that has bad flushing and diarrhea despite being on long-acting octreotide? Would you consider PRT for a patient like this, just for symptom control?
That's a great question. So we know PRRT does help with these exact symptoms. And the patients in the Nutter-1 trial that sort of was the big trial to demonstrate how well PRRT works, were kind of in similar situations to this patient in that they had avid tumors like this, but their symptoms were progressing on, or at least persistent on, somatostatin analogs. And also, I will say, if we could go back to a view of the case, thank you. You can see there that there's really excellent uptake in the tumors here. And so from that perspective, the patient would be an excellent candidate for PRRT. One thing I would say, though, one hesitation that I would have for doing it right now, PRRT is not something that you can do too many times. You want to do it at the right time when it's going to have the most benefit. And for right now, it seems to be really, especially now that the patient's had surgery, it's pretty much exclusively in the liver. And that kind of suggests to me that there might be a role for something directed just to the liver, and that we might hold off on PRRT until the disease has spread outside the liver.
Perfect. So that puts a beautiful transition to our colleague, Dr. Ahmed. So Oz, what do you think? Is this a candidate for liver-directed therapy? And if yes, what type of liver-directed therapy?
Yeah, definitely. You stole my thunder a little bit in explaining that this is a ideal candidate for liver-directed therapy, specifically because, at this point, most, if not all, of the tumor burden is confined to the liver. With liver-directed therapy, we have two primary treatment options that we use. One being percutaneous ablation, and the other being intraarterial therapy. In this situation, because there's multifocal tumor throughout the liver, we would opt for intraarterial therapy, so we could treat or blanket the liver with our therapy. So in this situation, I would choose something like bland embolization, where we would go and catheterize the hepatic artery, doing an angiogram, and then inject bland beads into the right hepatic lobe, and then followed by 1 month treat the left hepatic lobe.
Fantastic. And as the surgeon on the panel, I will add that this is way too much tumor for me to take out. So even if I wanted, and I would be really motivated to try to get it out, this is a lot of liver tumor burden, right? So this is definitely not something that I would operate on. So this is what we did. We got liver-directed therapy. This is actually a real case. And you see here that it actually got a lot better already. So the tumor actually not only stabilized, but shrunk, and her symptoms dramatically improved. Her serotonin dropped to 350 from over 1300, and she was a really happy camper for quite some time. And she did continue the octreotide and had a really good quality of life. So, Dr. Chan, would you continue the octreotide in this case, or because you said, well, liver-directed therapy worked, serotonin dropped, we can stop it?
I would also continue with the somatostatin analog. I think many patients who have carcinoid syndrome still benefit from continuation of the SSA to reduce hormone secretion as much as possible. And it also may, in the long run, by getting better hormone control, also we would hope prevent development of longer term complications from having sustained high levels of hormone, like development of carcinoid heart disease or mesenteric fibrosis down the line. So I tend to continue, even if there is improvement after embolization.
Perfect. Okay, so 2.5 years later, she has a return of her symptoms. She comes back to clinic, obviously complaining this time again about diarrhea and flushing that got worse. Her serotonin increased again to 900. So what now, Dr. Liao?
So I would want to get another set of imaging to see what's going on. This sounds like she has disease progression. So it looks like she does have disease progression.
Yeah, so
Looks
her
like both
MRI
within the
showed
liver but
increased.
outside the liver.
Right. So there are two tiny foci that you can see here that now are outside the liver. And like you suggested, Dr. Liao, clearly there has been progression in the liver. Dr. Heath, what are we doing now?
Well, I will say because the disease is still mainly in the liver, I would still probably at least run the idea by my interventional radiology colleague to see if they felt that there was something else that was indicated. However, the fact that it is starting to spread outside the liver is a sign that it might be time to consider PRRT. And just as on the prior study, it's tough to see those little lesions, and the uptake probably looks really low because the lesions outside the liver are so little. But the lesions that are good enough size, we can see there's a lot of uptake there. And if something's that bright on the PET scan, you also know that a lot of PRRT is going to go there and treat those tumors. So I think this could be a good time to consider PRRT.
This is what we did. I took Oz out of the equation there. Although you're absolutely right. I think it would have been absolutely reasonable to go back to our interventional radiology group. And I would even add, and maybe you can comment on that, Oz, is there a limited amount of time you can use blend embolization in a patient, or can you use it over and over again?
No, I think those are all fantastic points, and I think it's very reasonable to proceed with PRRT here, as mentioned, for the reason that there is evidence of disease outside of the liver. But again, I think if we wanted to make an argument for repeat intra-arterial therapy here, given that probably 95% of the disease is still localized within the liver, I think that's totally reasonable. There's two things that I would want to make sure of. One would be I'd want to make sure that on this MRI that the tumors, that there is arterial enhancement, because what we are targeting is the arteries of the tumor. And so we want to make sure that there's arteries feeding, which again, usually is the case, if not almost always is the case. And then the second is I just want to make sure that the liver is still healthy. And by healthy, meaning want to make sure that the liver function tests are acceptable and that the patient's in a good health status. Just like our oncology colleagues assess the health of the patient prior to treatment, we do the same exact thing. We want to make sure our patients are healthy and that specifically the liver can withstand another round of basically targeted therapy to the liver.
Perfect. Thank you. All right. Case number 2, 55-year-old male. Presents with flushing, diarrhea, and lower extremity swelling. Biopsy, same as before, well differentiated. Neuroendocrine tumor, low grade, stage 4. Liver biopsy is here. Serotonin 1500, a little higher than the previous patient. Chromogranin 3554. Patient gets a CT scan, which showed a few small lesions on the right side, but mostly really a pretty large lesion here, as you can see on the left side of the liver in the left lateral segment. The CT scan shows clusters of lymph nodes around one of the mesenteric vessels that supplied the small bowel, and the primary tumor was not seen on the CT scan. This time, again, we got an echo, especially because of the dilated lower extremity. Like Dr. Liao suggested before, we want to be wary about these patients that have high serotonin level to make sure that they don't have any problems with their heart valves before we intervene further. Dr. Liao, what would you do for this patient at this point?
So I think it's time to get our cardiology colleagues involved to see how we can address the tricuspid regurgitation if the valve needs to be fixed, because that can impact future treatment options, including surgical options.
Good. So I assume we all agree that we would start him on octreotide as well. We did get our cardiology colleagues involved, and they actually recommended a valve replacement because the valve was so damaged and the patient was severely symptomatic that this was the only way that they thought would be reasonable to manage him. And so that was done successfully. The patient did well afterwards. What now? Now we got the patient on octreotide, the heart valves fixed. You saw the tumor burden, which is mostly in the left lobe of the liver, and there's a primary tumor there in the small bowel. Dr. Chan, is this something you would send to your surgeons, or is this something that you would watch for a little bit, or what would you do?
I would, in a case like this, definitely have one of my surgical oncology colleagues weigh in, especially with that large mass involving the left lobe. That may be something that can be resected, and then you've really essentially debulked a lot of the liver disease, and at the same time also get an opinion about potentially also removing the primary tumor. It's not symptomatic now, so it may not be quite as critical as in the first case, but still, I think something to potentially consider.
Fantastic. So he was on 3 months of octreotide. We did some repeat imaging, no surprises. Everything stayed stable. And by the way, we did get a dotatate PET just to make Dr. Lawhn Heath happy. She got he had 4 small foci of uptake in T5 and T6. But really, like you said, Dr. Chan, the bulk of the disease was in that left lateral segment. And so because of the symptoms, he was presented to me, and I thought that exactly like you, that I thought it was very reasonable to go ahead. And, since I'm in the abdomen, I may as well just take the primary tumor out at the same time. So, and the gallbladder as well. So that's what we did. And the patient actually had a really good recovery. His serotonin level normalized actually after surgery, proving that most of at least the functioning tumor mass was in that left lateral segment. And he became asymptomatic. Now, do we continue SSA after this? Dr. Liao, any idea?
I would say it depends on how much of the disease the surgeon was able to resect. Generally, if it's most
In
of the
this case, I was
disease,
very confident, 99%.
then it may be, if she's asymptomatic, her serotonin is dropping, then it may be time to take a break from SSA.
Courtney, any recommendations on your end on this?
We do know SSA is fairly benign from a side effects standpoint, so I feel pretty ambivalent about whether or not to continue. I think it would be fine to continue, but I understand the rationale behind stopping. Definitely don't think PRT is a good thing at this point.
Dr. Chan, do you continue octreotide after surgical debulking at your institution?
Yeah, I think in a case like this, I think there are, the two options that have been discussed, continue or stop, are both quite reasonable, where you've debulked most of the disease. I will say that I do have a low threshold for continuing SSA in patients who we know have functional tumors, and especially in this patient who had carcinoid heart disease. I think the long-term hormone control can be beneficial, so I think my inclination would be, even though you've removed much of the disease, to probably continue.
Okay. So in this case, actually, we had a discussion with the patient. He wanted rather not have the shot in the butt unless he had to on a monthly basis. So we continued with just close serotonin and MRI levels. So there was no recurrent disease in the liver, as you can see here. And then about 2.5 years later, he developed a cervical mass that his wife noticed. He went to a local ENT doctor who performed the resection, and lo and behold, the resection showed a metastatic well-differentiated neuroendocrine tumor, this time grade 2 with a Ki-67 of 5%. We obtained a dotatate PET-CT, and this is what it showed. So as a hint, since I can't show you the entire PET scan, almost all of the disease, except for a few small lesions in the liver, but most of the disease is truly in the skeleton, so in the bone here. So what now? Andy?
Right, you can consider resuming that. If he was on SSA and this developed, then maybe consider PRT.
So we started him back on his SSA. Serotonin level grew or climbed mildly. Jen, is this something that you see often, that the functioning part of the disease is the one that's in the abdomen or the liver, and that patients with bone metastases don't necessarily have a high serotonin level and don't have that many symptoms like this patient?
Yeah, I think a lot of the symptoms with carcinoid syndrome are probably driven by hormone that's secreted by liver disease. So I think it's not entirely surprising, especially where it's now bone predominant, not so much in the liver.
So 2 years after octreotide, he gets a surveillance total PET CT, and this is what it shows now. So we're going from, fair amount of liver disease to really a fair amount of bone disease to a lot of bone disease. Courtney, what now?
I think now would be a great time for PRRT. Like the previous patient, this patient has very strong uptake in their tumors. Sometimes people ask me, in patients with an extensive amount of tumor in the bones, like we see in this patient in the after picture, sometimes other physicians will raise concerns, are you worried treating this patient with PRRT that they'll have more toxicity to their bone marrow than patients with less disease? But really, we've not really seen that. I think the disease must have to be really extensive and really just replacing all the marrow to see that. We do know there's some marrotoxicity to begin with PRRT, but somebody with this much disease, even though it looks like quite a lot, as long as their blood cell counts were good at baseline and were strong enough for us to be safe to do PRRT, I'd expect them to be able to handle it just like anybody else.
Great. So that's what we did. We started him on PRT. He had 4 cycles, and so far his disease has been stable. So I think these first 2 cases of small bowel neuroendocrine tumors just showed you that things may appear very similar on the first biopsy, but the course can be very different. And there's a lot of factors that plays into that. Liver tumor burden is certainly one of them. Avidity on the PET scan is one of them. Whether somebody goes to the operating room is one of them. So there's a lot of things that can change our management as we move along through the lifetime of a patient, depending on what the tumor does. And I think what is really astonishing here is that I think we all come from different institutions on the East Coast, on the West Coast, and in the Midwest. But ultimately, I think we all pretty much came up with the same therapeutic plan here. So I think that shows you that there is certainly variability, but that overall, there are some certain ground rule, I think, that we all follow. All right, so let's move on to case number 3. It's a 62-year-old male with a newly diagnosed pancreatic neuroendocrine tumor. The Ki-67 is 7%. It's a grade 2 tumor. And one of the things that I like to hear the least when I read a radiology report is innumerable bilobar liver metastasis and a pancreatic tail mass. Not because I'm worried about the patients with innumerable bilobar liver metastasis, but because I often wonder if the radiologist stops counting after 20. So I like to see the scan before I really consider this as innumerable. But in this case, all credit to our radiology colleagues. There were a lot of liver metastases, as you can see here with the blue arrows. And if you would count them, they would probably be well above 50. So we obviously don't expect them to count each and single one of them. You see a pancreatic tail mass on the right imaging there. That's about 2.5 centimeters. So he was started on octreotide, right? We don't have to go through that again. That's sort of the standard therapy, and returns 3 months later for surveillance imaging. So the repeat MRI shows overall stable liver lesions, but there's some progression of the primary tumor, mildly, from 2.5 to 2.9 centimeters. Dr. Liao, what would you do now?
If it's mild progression and patient's overall clinically stable, you could continue treating, but then this may be a situation where you want to talk about the role of surgical treatment. So discuss a multi-D tumor board and then send to Dr. Keutgen.
Great. So in this case, he was discussed, and I thought that he would get more bang out of the buck, so to speak, if we were able to shrink his liver disease. And so we came up with the idea to start him on Keutgen, which is a chemotherapeutic agent, and to continue octreotide. So we continued for a total of 12 months, and lo and behold, the next MRI showed there was a significant decrease in size of multiple hepatic lesions and also of the primary tumor. I mean, you're looking at now just really less than 10 lesions that were left. So he had a really amazing response. Dr. Chen, what would you do in this case?
I think where he's gotten a really excellent response to chemotherapy, it's worth, again, discussing back at the tumor board to think about resection to try to debulk some of this disease. It is actually really interesting. It's always hard to predict when you start chemotherapy what type of response you're going to get. But I think especially in these excellent responders, it is, I think, worthwhile thinking about debulking where some of the lesions that you'd seen before you don't clearly see right now. So I'd be curious to see what your thoughts were when you re-reviewed the case.
These were exactly our thoughts. So actually, we did repeat a dotatate PET-CT just to make sure, that there was nothing outside of the liver or no significant tumor burden that was outside of the liver and the pancreatic tail mass, just to be sure that it was worth our while going back in there. And we did take him to the OR. We did a distal pancreatectomy, splenectomy, and liver debulking. And you can see here we could only find 15 lesions. So we ablated 6, resected 9. We also did a cholecystectomy. And interestingly, the pathology showed that it was a grade 1 tumor now and not a grade 2 anymore. This is pathology from both the primary as well as the liver metastases. So, Dr. Liao, do you see that patients sometimes can have a lower grade after being treated with chemotherapy?
We do definitely see a lot of heterogeneity depending on where you biopsy, depending on whether it's the primary tumor versus the metastatic lesion, and even depending on, different metastatic lesions. And sometimes you can even see differences in terms of how these lesions light up on, for instance, on PET scan. Some of them will have more somatostatin receptor expression. They will light up more brightly, and then if you biopsy them, they may be of lower grade or lower KX67 than the faster growing liver metastases. So definitely a lot of heterogeneity.
Okay, we're back to the same question of octreotide. Yes, so, Dr. Chen, any ideas or advice? Do you treat your pancreatic neuroendocrine tumors differently than your small bowel neuroendocrine tumors after surgical resection for metastatic disease?
Yeah, I think as you look at this case, and if all disease that you knew about preoperatively has been resected, there are no hormonal syndromes that you're trying to control with the SSA, I think it's very reasonable to stop treatment and just follow. So I would probably in this case favor stopping and watching very closely.
Okay, so that's what we did. 2 years later, no evidence of disease progression. That's what his liver looks like. So that's a really good outcome. So now we got a 55-year-old female with a newly diagnosed pancreatic neuroendocrine tumors. Same startup, so to speak. It's a grade 2, Cas77%, stage 4 disease. The imaging again shows innumerable bilobal liver metastases in the pancreatic tail mass. Now this is what the liver looks like. There seemed to be perhaps even more tumor than in the previous scan. And this is what the dotatate PET looks like. So you can see the dark spots are all liver disease. So he was started on long-acting octreotide, same story, returned 3 months for surveillance imaging. And now there's some mild progression of the liver tumors. What now? Oz, is this something that you would recommend liver-directed therapy for?
Yeah, I think good question, and I think the same principles still apply here. So we don't really discriminate based on tumor burden as long as there's still functioning liver there, and the liver function is normal, meaning the liver function tests are okay, and the patient's overall general health status is okay. We can still do an intraarterial therapy again because there's more than a few lesions here. There's obviously multiple lesions here. I would favor something like a bland embolization if we wanted to go the liver-directed therapy route.
Andy, any role for CAPE-TEM?
Yeah, definitely. For pancreatic neuroendocrine tumors, it's one of the therapy options that can actually produce a objective response. So, meaning tumor shrinkage and in a relatively short amount of time. So, it might be, someone, let's say you worry about them going to liver failure and you need that response. That may be a situation where you would start the CAPE-TEM.
Dr. Chan, what do you think?
I completely agree with Dr. Liao. I often, as I evaluate patients, when I see that much liver disease at the outset, where the liver is already enlarged, you worry about progression and how much more progression the liver might tolerate. So I sometimes start out with chemotherapy when there's a large burden of disease like this.
So that's what we did. We started chemotherapy, and actually repeat imaging after 6 months of Keutgen showed mild progression of disease still. So then we went the IR route, and the bland embolization was actually very successful in this patient. He had first the right and then the left lobe that was embolized. And you could see here that there's definitely decrease in his overall liver tumor burden. But unfortunately, 9 months later, he again experienced progression of disease in his liver. So what are we doing now? Courtney?
Kind of like a few cases ago, I would still probably give my interventional radiology colleague the right of first refusal here. Also, at my institution, in addition to bland embo, they do a lot of Y90 in situations like this. And so it's possible that interventional radiology may feel that another round of treatment is indicated. But this could potentially be a time to consider PRRT. There are a couple of things that I would think about, though, in this patient. If there's not too much healthy liver left, sometimes we worry that radiation may damage some of the healthy remaining liver, but that's not a concern in this patient. The other thing that was giving me pause as we were talking through the case is, generally when patients get Keutgen, there is some risk to the bone marrow. And when patients get PRRT after getting Keutgen, they may be at increased risk of marrow toxicity. Doesn't necessarily mean at all that they can't get PRRT or shouldn't get PRRT, but it's just one of those things that I would want to pay extra careful attention to their blood counts over time.
Outstanding. So let me just turf it right back to Oz. Oz, 2 points that Courtney brings up. The first one is giving you sort of the right of refusal again, right? So I think it's a very good point. Is there any time frame that you say, liver-directed's been 9 months ago? He had good response, granted, but is 9 months too short to go again? Or is there any time frame where you would think oncologically wouldn't make sense to retreat? That's my first question. And then my second question is, what about Y90? Do you use it for NETs?
Yeah. So to address your first question, I mean, a lot of what we do isn't terribly scientific, in terms of the, standardized protocols and algorithms. To be honest with you, it's a lot more common sense. So if the patient's doing well after a bland embolization, for example, I mentioned when we do whole liver treatment, we separate each half of the liver, so right and left, by 1 month. And I've done patients where I've done right, left, and then gone back and then the right again after sequential months, just to sort of finish off the job, if that makes sense. So to answer your question, I would pursue treatment after 9 months, again, provided the patient was healthy and did well the first time, which in this case she did. When does it not make sense? I think it's more going to be based off of that MRI. If I don't see a lot of arterial enhancement, or it looks more heterogeneous, or the liver function is not doing well, I would probably shy away from that and then sort of rediscuss with Andy and you at the tumor board. With respect to Y90, I think we tend, as a institution, as a group, to shy away from it. I think as a society of interventional radiologists, most academic interventional radiologists are not performing Y90 because of the risk of chronic hepatotoxicity, which is a very fancy way of saying that we cause liver cirrhosis with Y90. With Y90, we use it for a lot of other tumors, and unfortunately, those patients don't have a long lifespan. And with NET, because those patients do have a longer lifespan, they actually unfortunately see the side effects or the toxicity of long-term Y90, which is basically this hepatotoxicity or cirrhosis. So we tend to shy away from it. Now, with that said, I know we were chatting very recently about some encouraging data from Penn about combining Y90 with Keutgen for grade 2 NETs. But again, a lot of that's early and it remains to be seen. But I think the nice thing about NET is that we have a lot of treatment options available to us, including PRT. So I tend to stay away from it, in the short term.
Courtney, do you have any reservation about giving PRT to someone that had Y90? So the word here is cumulative radiotoxicity.
Short answer is yes. I do have reservations worrying about cumulative radiotoxicity to the liver. This is something that just because of the practice patterns at my institution, though, we do end up actually doing PRRT very often after Y90, sometimes after multiple rounds of Y90, and generally have not, seen too much radiation-related hepatic toxicity, but we haven't seen zero. Do you know what I mean? So we do occasionally have a case. It's usually when the patient is heavily pre-treated, has gotten multiple rounds of therapy, multiple rounds of Y90, potentially a bilobar Y90, even over various time points, and still has a really high burden of avid disease in the liver. So I think it's like a lot of factors that have to come together at once. But it's not my first choice in that sort of setting.
Great. And then Andy, so this patient, right, so had Keutgen, didn't really respond, actually progressed mildly on Keutgen, initially responded well to liver-directed, but is there any reason why you would want to rebiopsy this tumor at some point? I mean, the time frame is relatively short on how quickly the patient is progressing. I mean, is this something that you would consider?
Yeah, every now and then you see someone's disease kind of take on an unusual course, like, indolent for a few years. And then after like CAPE-10 and PRT and all these treatments start to take off more rapidly. And when that happens, sometimes I usually kind of re-image them and consider rebiopsy because every now and then you find this fast-growing clone that may even be poorly differentiated.
So in this case, we did a repeat liver biopsy, actually our interventional radiology colleagues did this for us, and showed this time that it was still a well-differentiated tumor, but the Ki67 was 30%, so it went from sort of a grade 2 to a grade 3 tumor. While we had the biopsy specimen, we also did a next-generation sequencing panel on it, and it showed an ATRX mutation, which is very common, but also loss of RB, which is a gene that has been associated with other types of tumors and sometimes can be associated with pancreatic neuroendocrine tumors. The dotatate shows, again, mostly disease within the liver. It's still avid disease. Jen, what do you do in a patient like this?
Many of the conversations that we've already had with respect to should we go back and re-embolize, should we consider PRT, I think they're still very relevant topics to discuss given that it's liver predominant. I think when we tend to see higher grade disease, I think we also can consider chemotherapy. This patient has already had capecitabine and temozolomide, so I don't think we would necessarily return to that. But other regimens that do appear to be active with well-diff grade 3 neuroendocrine tumors of the pancreas include regimens like Folfox. But I do think that there also is a role for PRT and liver-directed therapy. So I think those need to be discussed again in a multi-D setting just to figure out which one would be most appropriate now for the patient.
So Courtney, what's your experience? I think that's the last question, but what's your experience with grade 3 tumors and PRT?
We definitely do PRT in well-diff grade 3 tumors. And essentially, like for us, it's not the grade that's important or the Ki, it's the imaging and how hot are the tumors on imaging. And are there any significant tumors that are not hot on dotatate? Because then we worry that we're going to be treating some tumors and then other tumors are going to be sort of growing not in it, like are not being treated, and so they may grow out of control. But barring something like that, as long as the uptake is as good as it is in this patient, we're very comfortable treating grade 3 patients. Do generally find that response rates are somewhat lower, and the duration of the response tends to be somewhat less. But particularly in patients like this that have already been through a few lines of therapy, this can definitely buy some time. And this might just be the right time to do that in this patient.
Great. I think that's it. So I'd like to thank you very much. I hope that we showed our patients that, again, tumors can appear very similar in the beginning, but that things change. Dependent obviously on tumor biology, every tumor may look the same under the microscope, but may behave very differently or respond very differently to therapies. So I hope that this was useful to you. I'd like to thank, of course, the panel here for your outstanding comments and insights on how you would treat these patients. And we will see each other very soon for the next session. Thank you very much.